Dr. Lam, are there any pitfalls in the management of electrolytes in diabetic ketoacidosis that you would like to make the audience aware of?
Sure. Thank you. I kind of glazed over those slides in the interest of time, but I would say that the number one is with hypokalemia. So a lot of times on admission, there appears to be hyperkalemia on the blood work. However, they're usually total body potassium. There's a total body potassium deficit, and with insulin therapy, you potentiate hypokalemia. So it's always important to proactively replete, adding it to the IV fluids, even when the potassium may appear normal.
Before reading the questions, I also have a question for Dr. Lam. You won't get away with it. About 1 in 200 type 1 diabetics are estimated to have Addison's disease. If a patient comes to the ER with DKA, when would you test? When would you think you would test for Addison's disease in addition to the DKA?
I think that any time where there is in the initial therapy, a lot of times they've received volumes of fluid to the when they're first in the emergency room. If their blood pressure is really not responsive, they're having symptoms of hypotension, then I would certainly entertain the possibility of Addison's disease. You can also, if you're in a relatively large center, measuring a cortisol, which should be very high in the setting of diabetic ketoacidosis, is an easy way. But really, as with all cases of adrenal insufficiency, it's oftentimes better to err on the side of safety to treat, and then to sort of evaluate when the patient's more clinically stable.
Okay. We have quite a few questions, so we'll try to do some of them. One is for Dr. Barry Weinstein. You get a double. Twofold question. Patients taking 50 to 70 units of basal, what is the cutoff point where decrease in fasting blood glucose are significant? Insignificant or significant? Insignificant.
So the following question after that is actually the patient on the same amount of 50 to 70 units of basal, and then they're on a bolus of about 5 to 7 with 3 meals. What would be the reason for such an insulin regimen? So I think I'll address both of them together. So again, as we talked about, so when patients come in as a new consult and I see a regimen like this, red flags are going off of what I was talking about before, about this is covering postprandial hyperglycemia. The patient's never truly in a fasting state, which can lead to hypoglycemia later on. But the other problem is that I don't want to make too many changes and the patient, gets nervous. And so in terms of what is insignificant, I think their overall control is what is important. If you're just talking about this amount of units, it's looking for that hypoglycemia. If they're otherwise stable and they're doing well, I may not rock the boat too much, even though personally I would prefer to lower the basal insulin in this case and then add on the bolus with their meals. So then when you have this situation where that bolus is already there, it's very interesting. I had a recent situation. I will fully admit what happened is the patient came. They were on so much basal, maybe almost like 100 units and like 4 units before each meal. And so my plan, which I told the patient, was to slowly reduce the basal and slowly increase the bolus over time, not do it overnight. As I mentioned, does not have to be done overnight. The patient got very upset and went to one of my colleagues that I didn't know what I was doing. So I learned my lesson that you don't want to rock the boat too much and overall control. In the end of the day, you don't want excursions in either direction. And if they're kind of stable, then you have time slowly to make adjustments. So in that situation, I would slowly reduce the basal and then slowly increase the bolus insulin to help the regimen to be more appropriate for the natural physiological, to meet the natural physiological needs. I hope that answers it.
Okay, I have 2 questions for Dr. Robinson-Rapp. The first one is a very practical one, whether Pregabalin is considered on the iStop PMP website as a controlled substance?
Yes. So pregabalin is a low-level Schedule 5 controlled substance. And the reason for that is that in the clinical trials, some patients reported liking their pregabalin. We're not really sure what that means, but a lot of the anti-epileptics, unfortunately, now are being subject to this question of whether there's a possible euphoric effect with them, which is really bad news for anti-epileptics, because if you're treating your patient for neuropathy and they run out of their drug, well, that's not the end of the world. But if you're treating them for seizures and they run out of their drug, that's really bad. So what that means for us is that we, at least in New York State, I'm not sure if it's different in other states, Lyrica has to be written on paper. Because it's a Schedule 5 and not a Schedule 1, we are allowed to write refills, so that's good. But it does have to go on paper and it can't be ERX'd here.
And one
I
more.
don't consider it addictive, though.
Okay, 2 more quick questions. One is about alpha-lipoic acid for neuropathy.
So alpha-lipoic acid, there's been some work in the use of it. I think that some people will give it because it probably doesn't hurt. I think overall the data is not great that it helps either, but it's certainly something that could be fine to use.
And another question, can you have neuropathy when the EMG is normal?
Absolutely. So you can definitely have neuropathy when the EMG is normal, and that happens if you have a predominantly small fiber neuropathy. So in any given nerve, there are different sizes of fibers. The larger ones are the ones that do motor function and do sensory function like vibration, and the smaller ones are the ones that do pain and temperature. And so you could have a lot of pain from neuropathy if you have an exclusively small fiber neuropathy and have a totally normal EMG. If that's the case, and it's really important to prove that the patient has neuropathy for some reason, then the skin biopsy is the way to go with that, or autonomic testing can also show it.
Dr. Lam, what's your glycemic targets with somebody with hypoglycemia unawareness and significant neuropathy?
So, I tell my patients at the very least, or mostly for all, if they're randomly checking their blood sugars, at least if they notice that there's an overall trend less than 80, then they need to call me. Certainly if the person has unawareness and also neuropathy, less than 100, I'd like them to call me. And it really depends too, I don't think I can give like a blanket statement in terms of, what everyone's goal should be that has neuropathy as well as unawareness. I think that you really have to take a look at their trends of blood sugars, see when their most problematic times are at night or during the day. But I would say definitely, above 100 probably for that patient.
Dr. Weinstein, you have a patient that insists on taking the Rapidacting after the meals. What would you do?
So just so you know, so the problem of taking the rapid-acting insulin at meals is, the insulin is going to last longer than the absorption of the food, and you run the risk of having delayed hypoglycemia. Oftentimes, surprisingly and shockingly, the patient does not make the connection to why they are having hypoglycemia a couple hours later and the insulin after. So I really try to advise, I know it is not practical oftentimes for patients to take it 5 to 15 minutes before, and I find that it's very important, especially for type 1 diabetics to do that sometimes, but for a type 2 diabetic, if you can just at least get them to take it either before or at the start of the meal, it's just very important. After the meal, you just need to emphasize the risk of hypoglycememia. If they're not going low after the meal, it's most likely because they're not on enough rapid-acting insulin to begin with. And then that's the problem. If that you then increase to an appropriate dose, they'll start going low and they'll start to realize. But just emphasize to them that if they can't take it before, to at least do it at the start of the meal.
And another one for you, Dr. Weinstein. When to increase glargine instead of adding rapid insulin? And what would be the max dose of glargine that you would use?
So there's no max dose of glargine that I would use in theory when I'm using a rapid-acting insulin. I do stick to the 0.5 units per kg with basal insulin if they're not on bolus insulin. So I'll have a patient when they come in and I'm starting the basal insulin, I will literally, on that page where I'm writing the instructions, I will say whatever their body weight is, do not go above 30, do not go above 40, do not go above 20. I mean, it really depends on the patient's weight. And so I am pretty strict with that 0.5 per unit K ratio and when I will tell them not to go above. Does that answer the question?
Yep. Dr. Robinson-Rapp, vitamins, are they of any use?
Are they of use or often used?
Of any use.
Of any use.
They are often used, but are they of any use?
They are probably not of use unless someone is vitamin deficient. Again, it's not going to hurt probably, except for vitamin B6, which in excess causes neuropathy. So you don't want people to be on like mega doses of B complex. Sometimes people will think, you know, B12 is good for neuropathy. They'll be on a really large dose of the B complex, and then it could actually make things worse. I do tend, if people are running their B12s, you know, in the low normal range, then sometimes I'll just supplement them. I figure it doesn't hurt. Does it definitely help? I usually try to run them a little bit higher. You know, if our normal range in our lab, the low end is like 180. So people who are in the 200s, 300s, I'll give them a little extra. Not evidence-based.
I don't know to whom this question is, either Dr. Lam or Dr. Weinstein, but somebody asked about the black box warning for metformin with creatinine of 1.5. The question is, please comment. So the comment is that you have to go by this black box more warning, but do you want to comment on
Sure.
what do you do with those patients that are starting to hover around 1.4, 1.5, 1.3?
Yeah, no, certainly. So, you know, a lot of the data for lactic acidosis for biguanides are more from fenformin and less so from metformin. And a lot of these times where you're developing lactic acidosis, there's also another precipitating illness. They're septic, or there's some other disease process that's predisposing them to ischemia. I mean, a black box warning is a black box warning. You know, you have to be very open with your patients about it. Just like people become really liking their Pregabalin, some of my patients really like their metformin, and it becomes a little bit of a struggle. You have to be very open with them that they are running a risk and that their kidney function has to be monitored very closely, their GFR, and you have to, you know, counsel them if they are sick, dehydrated, they are having, you know, obviously if they're going in for iodinated contrast procedures, that they need to hold their metformin and their creatinine needs to be measured afterwards. But, you know, I think you have to have an open conversation with your patient and talk to them about the risks.
A few more quick ones. Dr. Weinstein, what's your opinion about splitting long-acting insulins, like glargine, instead of 60 at night, 30 and 30?
Mm-hmm. So I'm just going to make a blanket statement about why I was focusing on once you get to a certain basal dose to split. Patients are coming to us and they've on basal insulin in these large doses, whether or not it's once or twice a day, and their A1Cs are just not getting to goal. You just can't get them controlled and where they need to be if you don't add bolus insulin, because again, you're not treating the hyperglycemia appropriately. When you do, if you have patients that need to be on that higher dose of basal insulin, and they're on bolus insulin as well, then yes, splitting the dose can be very helpful to get better absorption. You can get some better results. So usually if I have a patient who's getting up into those high ranges, you know, 80 and 90 and 100, then I will start to split them into twice a day dosing. But those, again, are patients that I have on rapid-acting insulin before there's meals.
Okay, two more quick questions.
And I would not start, there's a question there, I would not start somebody on 60 twice a day of Lantus. No matter how much somebody weighs, that's probably not inappropriate. It would be once a day Lantus with rapid-acting before their meals.
And two last quick questions. Dr. Robinson-Rapp, can you give Pregabalin in the setting of renal insufficiency?
You can, you just have to give a lower dose. So it's renally excreted. So in somebody who has some renal insufficiency, I would just go very, very tiny to start with. You can give them 25.
And this is a last question. It's actually could trigger a 1-hour lecture, but in any event, Dr. Weinstein, can you comment on the challenges of taking care of patients with diabetes triggered by atypical antidepressants, or more common?
About what?
Atypical antidepressants causing diabetes.
I think in a lot of these patients, you have a situation where the benefits of their medications outweigh the risks of taking them off. So you have a medication that's causing a side effect, causing metabolic syndrome, and you deal with it. You make sure, I guess from the community standpoint, they need to make sure that they're following someone who's monitoring their A1Cs. Sometimes the A1Cs just stay in the borderline range. Metformin is a fantastic medication if the kidney and liver function allow. It's a fantastic medication for these patients. And then you just follow them like you would with any other diabetic. I do usually make sure that the medication they need to be on that medication, that there isn't an alternative medication that would have less of a diabetes risk over time. But in the beginning stages, metformin can be quite excellent for them. Some of them need to move on to insulin, some of them don't.
Thank you very much. There's many more excellent questions. We couldn't answer all of them, but you can definitely approach the panel at lunch and ask them those questions that weren't answered. Thank you very much.